As I was graciously introduced, I'm a senior staff psychiatrist at Henry Ford Hospital, and I work with dual diagnosis. So primarily severe mental health disorders and substance use. And I was really interested in the programming you guys have going on here, and was asked to give a talk about substance use and addictive disorders. Can everybody hear me okay? I just want to make sure. Okay. Bring it closer. Okay, is this good? Okay, good. So I was asked to talk about substance use disorders, and actually it's a lot more complicated than talking about substance use disorders in the Arab American population in particular. The DSM, so the Diagnostic Manual for Mental Health Disorders that was created by the American Psychiatric Association, is actually a very Western text. So it was created with a Western population in mind. It was created with the trials and tribulations of people who exist effectively in the scope of the Western world. How many people here were either born outside of the country or have parents who were born outside of the country? Can I see hands? So that's almost everybody, right? And I know for me, both of my parents were refugees, and my father fought in the 1967 war, in the Six-Day War in Palestine. So that comes with a completely different narrative, completely different susceptibilities than the general population here in the United States. So before we can talk about substance use, we need to talk about the fallout of what being from such a volatile environment, whether you're from Iraq, Lebanon, Palestine, Syria, Egypt, you know, there's just tumultuous, everlasting war. So can we get the next slide? So this is actually a monument to soldiers that died in the Vietnam War. And that's around the time that the United States started to characterize what would ultimately become known in the 80s as post-traumatic stress disorder. It had a lot of different iterations. It was called shell shock. It was called reactive stress at one point. But the stereotypical image for somebody who is a survivor of PTSD has always been a soldier. You know, whether it's in media, movies, film, our own perceptions, it's been soldiers, effectively. But if we could get the next slide, and one more. It actually looks different to us. So, you know, I don't know if people can make out what that is, but it's a bunch of soldiers. It's a bunch of soldiers leading around folks who are in the Middle East. This is actually in Algeria in 1944. And this preceded a calamity where 45,000 people were executed. And this is, you know, we're talking about 80 years ago, right? So for the last basically 100 years, in the Middle East and in North Africa, we've been constantly at war. You know, irregardless of who is firing the gun, irregardless of who's dropping the bomb, you know, your parents, my parents, our grandparents, they've all heard gunfire, and they've all had people hold guns up to them. They've had to leave villages, leave homes, leave different areas. So this is sort of tailored to that. If we could get the next slide. So this is the Nakba. This is the Exodus of Palestinians. This was a catalyst for a lot of different negative events that happened all over the Middle East. And this is an example of trauma. If we could get the next slide. This is actually a picture from the front lines of Iraq and Iran during one of the bloodiest, most atrocious wars in human history. The loss of life was insane, and basically you had entire families that were decimated, completely gone, erased from history. Can we get the next slide? And this is a picture from Sabra and Shatila. So it's just going on and on. I mean, you can every decade. Can we get another slide? And then military factions. So we start to develop basically psychologically unstable warlords all across the land, right? This sort of demonic plague that manifested, the most recent one, that, when we could get the next slide, causes the exodus of people from their homes. So this is still happening. I mean, you still have refugees flooding from the exact same lands that they've been flooding from the last 100 years, still flooding today. People are being assailed in Eastern European countries as they try to escape the torment of either their dictator or the oppressive military regime or whatever And that's what our narrative is. It's a very different narrative than a Western narrative, and it's consistent. So before we talk about addiction, we need to understand and comprehend the trauma that our ancestors have experienced and that our forefathers have experienced. And then when we come to the United States, we usually aren't in the best of shape. I can say that from my family. I'm from the west side of Chicago. The majority of people I knew were living in very poor areas. People were getting shot at, held up at gas stations. You know, that's the story of what it is to be an immigrant from the Middle East. You come to the United States, and you're coming from one traumatic, sort of chaotic environment, and you're coming to another one where, you know, now you've got drugs offered to you, which that's kind of a sensical reaction as to why you would start using drugs. If you've already been abused and you've already been tortured and, you know, maybe you've lost faith in your ethnicity, who you are, and then you come and you got a job that is arduously in close proximity to violence. So I'm going to talk a little bit about trauma. So what is trauma? Can somebody define it so this is a little more interactive? You could speak. Huh? Something that scars you for life. Okay, that's a good answer. Anybody else have an example of trauma? Yeah, anything that, yeah, that's a very scientific answer. Yeah, anything that overwhelms the mind's ability to cope. Yeah, so trauma defined by the American Psychiatric and American Psychological Associations is roughly something that threatens your life or well-being, an event, the threat of sexual violence, or witnessing either of those. So that's how trauma is relatively defined, and that's a lot of things. That could be being held up at gunpoint. That could be a car accident. That could be a hurricane. That could be a volcano. That could be ISIS. What we know from epidemiologic studies is that trauma perpetrated by human beings is far, far more scarring and long-lasting and likely to develop into post-traumatic stress disorder than trauma that is, you know, from natural causes, say from an earthquake. So basically, trauma has two components to it. And you know, judging the amount of people here who were born in the Middle East or who lived in the Middle East, we all have to have some exposure to somebody with PTSD. The rates and estimates conservatively for refugees with post-traumatic stress disorder is 28%. And the higher end of those estimates are 80%. And in all reality, there's absolutely no way to calculate any of this because they're not going to participate in psychiatric treatment or psychological assessments when they get to the United States or whatever country they're going to. And out in the fields, you don't have people that are really qualified assessing this. But we know people are traumatized. People are ill, very, very ill. And trauma has two components. So it has a component that medically we would call an autonomic component. That's kind of the increase in blood pressure, the fluttering heart, the worry and anxiety that you might see when a dog chases after you. That's reactive, and it's reactive for a reason. You know, you need to get out of there. Your body adjusts to a certain situation, and you need to get out of that situation. This might cause you to sleep worse, right? Because you need to be more aroused to wake up because maybe some militants are going to come in. This might cause you to react more to stimuli. Like, let's say somebody slams a door. To you, that might sound like a bomb. That was classically observed in veterans of the Vietnam War, right? 4th of July, worst time at the Veterans Association in general in all major cities. I think we're okay, right? Can I keep talking? Okay, cool. So you have this autonomic instability, this physiologic reaction, and it's completely medical. So it's not something that you can say, just think away, right? You know, I think I'm about to have a seizure. I don't know about. No, it's all right. Okay, I think we're good. It's not something you can think away. It's something that is innately physiologic. Your brain in a region called the locus coeruleus produces norepinephrine and noradrenaline, and they pump you up. You have chronic changes in sleep architecture and cortisol. Those are physiologic reactions. That's one component of PTSD or of a traumatic syndrome. Because again, PTSD is defined per Western standards, for people that have been observed in the West for the last 40, 50 years, not per the population that we're talking about. And I don't mean to exclude anybody who's not, say, Arab American or from the Middle East, but I tailored this particular talk to that population. The next set of symptoms that you're going to have are cognitive distortions. And this is something that is absolutely consistent, what I've noticed throughout a lot of Arab populations. So people have told me this, you know, your mom will look and say, hey, you can't talk about this. Don't talk about this government. Don't talk about this. Don't say this. Don't say that. There's an air of fear in the population that's very, very pervasive. And it's not just sort of being in an Arab enclave or a cohort. I grew up in an Afro-Caribbean neighborhood, and this is exactly the same sort of behavior that I experienced. People are worried. Their thoughts about what the world is and how the world will greet you and treat you is completely different. You start to view the world as a very dark and scary place, which it can be, but that's problematic for a lot of different reasons because it hinders your progress and development. You start to have negative thoughts about yourself. How many people survived? I mean, pretty much anybody who has PTSD is a survivor, right? So who didn't survive? Plenty of people died. I mean, millions of people died in Iraq, right? I mean, who's left behind? You know, there's a degree of guilt felt there. Even though we don't necessarily comprehend it, we as Muslim Americans, as Arab Americans might not put the phrase guilt on it, but I mean, when everybody's gone and you're the only one left, that exists. And then negative perceptions of self, right? Being ashamed to be from the ethnicity that you're from. You know, are we just a bunch of warmongering humans out in the desert cutting each other's heads off? You know, those are thoughts that people start to develop and ruminate upon, and that is something that contributes to the way that people carry themselves through the world, but also the way that they raise their children, and then the fallout that exists in raising children, and the fallout that those children will have, particularly if they're in environments that are also hostile, which they often are. So these are some PET scans that basically show metabolism, brain metabolism, and this is really hard. It's going to be hard to describe with that, but basically, you see less red on the top line, right? Less red in the back of the brain, less red in the limbic structures in the brain. So the limbic structures in the brain really control a lot of automatic things. Fear, looking for food, looking for shelter. There's also some highlights where the fusiform face gyrus is. I don't want to make this too medical, but basically, the bottom picture is demonstrating that your visual cortex is working when you have PTSD, is working really hard, right? So people that have flashbacks, if you think about the old caricature of a veteran who comes back from war and he's pulling out an imaginary gun and firing it at air, that's substantiated. That's not just weakness of the mind, that's the mind creating that. It's an illness. It's a treatable illness, but it's an illness that's very hard to get at. And from my experience, being an Arab American stigmatizes that further and puts another layer in between you and appropriate treatment. So that's where drugs come into play. If we could go to the next slide. So addiction. What addiction is, so addiction is a nebulous term. It doesn't necessarily mean one thing or another. There's a way to define it that is based on psychological addiction. There's a way to define it based on physiologic necessity of a substance. Like if somebody's drinking a lot of alcohol for several weeks and they stop, even if they have the wherewithal to say, I don't want to drink any more alcohol, they could actually die, from having a withdrawal seizure. That's one form of addiction. Another form of addiction is nicotine dependence, where there's some physiologic dependency, but there's a lot of psychological dependency too. There's dependency on the action itself. And both of these actually increase dopamine. No matter what drug someone partakes in, they're increasing dopamine, and they're effectively mitigating a lot of the negative stressors that come from things like PTSD, which is very prevalent in the United States. So we're talking about 6%. The majority are women. Probably higher in the Arab American population. I would be interested to see what a study would say about that, but we just can't conduct one. And there's a greater susceptibility for drug use, and alcohol use disorder in particular, twice as high in this population. So when we see groups of people coming from abroad, coming from Iraq, coming from Mosul, coming from Yemen, coming from Sana'a, and now there's an alcohol epidemic in Dearborn, and now there's a heroin epidemic in Hamtramck, and, you know, what's going on? Well, you've got a lot of psychological issues that aren't being addressed. They're multi-generational, so we're not just talking about one generation, you know, we're talking about for the last 100 years, basically since the fall of the Ottoman Empire, and before that, you know, you've been shot at consistently. And now nobody's treating you, so you're going to treat yourself. You're going to get alcohol. Hopefully not anybody here and not you, but you know, it's a reality of life. I think I get a concerned parent's phone call, you know, twice a week discussing a child, you know, ubiquitously from the communities here in Southeast Michigan, from the Metro Detroit area, saying, I don't know what to do. It's something that we're all susceptible to some degree. No matter what the substance is, the net effect is the same. So, you know, I actually usually give an annual grand rounds on cannabis use disorder, but I think the last person who spoke on cannabis, right, or something like that. So, but cannabis, it's been completely destigmatized, and what it's doing is it's destroying at a faster rate minority communities, actually probably faster based on how many weed and smoke shops there are in poor inner city areas in Detroit. I mean, it's wreaking havoc, and you've got high potency cannabis floating around that didn't exist like 10 years ago. And its net effect is decreasing cognitive capabilities, increasing the risk of psychosis, and increasing dopamine, which is still an abusable drug to treat the issues that we're not treating in the community at large. And the same goes for opiates, the same goes for cocaine, things that cause general dopamine depletion and cause presynaptic cells, so cells that are upstream to release all of the neurotransmitters that make our brain feel good. You know, things that prayer, exercise, time with family, maternal and paternal bonding would naturally release, we're artificially going to and getting that from substances. And, you know, I don't want to say addiction is a lot of people judge substance users to a degree, I think, that is far more harsh than warranted. I mean, do you have a question? So melatonin is created in the brain endogenously. When you take melatonin, you're basically triggering a cascade that produces a sleep substance in your brain that's already being produced. It's not addictive. In fact, studies show that if you take like more than 6 milligrams, it doesn't do anything. No matter how much more you take, it's a placebo. So you can overdose on melatonin theoretically, but over-the-counter supplements, a lot of them, I mean, there are some that are horrible. Kratom is like poison, and people are using that all the time. But melatonin is just like something that you already produce that you're taking. May or may not work that well. Yeah. But these are the issues that we're facing. And if we could go to the next slide. And there's physiologic grounds for it. I don't want to like bore anybody or talk too much about science, but there's a neuronal network, the mesolimbic network, that we can see when it's damaged. We can see when it's out of balance. We can see when the connection between the nucleus accumbens and the VTA and the frontal lobe. So your judgment comes from your frontal lobe, right? That's where you stop yourself from doing things that are bad, you know, moral, ethically in line with what you believe is bad. Different regions cause different things. And basically you have a dopamine, a presynaptic protrusion from the limbic system, so from further in your brain that goes there, and that modulates rewards and pleasures. And when you take drugs, you screw that up. Like, it's genuinely messed up. And the thing is that when somebody who's on drugs is on drugs for an extended period of time, they're not getting high anymore. They're just trying to feel normal. And that's horrible. Like, you think about feeling terrible all the time except when you do something like crack cocaine. That's what the majority of cocaine users that I've treated experience. Nobody's doing it to have fun anymore, after a few years of doing it, after a few years of being addicted to it. We could go to the next slide. And to further substantiate that this is a physical illness, this is a physiologic illness, top scan is that of a brain. And because you deplete your dopamine stores and catecholamines and, you mess up the balance of neurotransmitters when you use cocaine, The first scan is that of a brain that's not on cocaine, and the second one, to your right, is one that is on cocaine. And you can see that there's substantially reduced activity because you become dependent on the cocaine. And the picture beneath it is that of a diseased heart, somebody with coronary artery disease who's not getting adequate blood flow and not getting adequate perfusion to the muscles in their heart, right? I mean, we're talking about a physical illness. So I think that perceiving substance use through the looking glass of it being a response to something that a lot of us have experienced is probably a more appropriate way than looking at it, say, as a social failure or a failure of society at large. That's all I have to say, I think, about that. Any questions? Or am I supposed to say that? Or? Okay, sure, yeah. Yeah, go. Sure, yeah, absolutely. So that's probably going to be in the next iteration of DSM. Internet gaming disorder is already an observable diagnosis, even if it's not in the DSM. It causes the same exact reward circuit pathway. So what's interesting is that in rats, and I don't want to compare humans to rats, but we do studies on rats, right? So the peak dopamine, so the peak excitement when a rat is addicted to cocaine isn't actually when they take the cocaine. It's right before. So it's right before. It's when the cocaine drops, so when basically the needle that feeds them the cocaine drops. That's where the peak dopaminergic activity occurs in the rat's brain, right? So there is a great degree of environmental and of physical addiction that can cause physiologic ramifications. Social media is the same thing. I mean, all that's engineered, right? The colors red and blue, you know, the idea of getting a lot of likes. And that's associated with a whole bunch, I mean, particularly in young females, that's associated with an extraordinarily higher rate of suicide. And there's a whole slew of, you know, garbage associated with social media, unfortunately, but that's only getting worse. Yeah. The difference is that the ramifications of chronic drug use will cause neurodegeneration. So it'll cause your brain, not your brain, but, you know, somebody's brain to atrophy and to, you know, look like the brain of somebody who's demented. Cocaine is very, very neurotoxic. And so is cannabis. Cannabis is neurotoxic too. And cannabis destroys people's hippocampuses. And the hippocampus is basically where you form new memories. I mean, it doesn't take a genius to put that together. But, I mean, the reality of it is that, you know, in the 1970s, where THC content was 4% in any given, you know, joint that somebody would smoke, you know, that's not the same cannabis that's 80% that you go get from a vape shop right now and that people are smoking. You know, it's inordinately neurotoxic, and it's associated with psychosis too. I think 2 years ago it would have been like a split room, but I think right now medically, I think it's pretty unanimous. Anxiety. Yeah. Sure. Yeah, there are. Yeah, there are. Particularly benzodiazepine addiction and anxiety, as Xanax is prevalent. I mean, people are abusing pills very frequently. But generalized anxiety disorder is actually the highest psychiatrically comorbid disorder with post-traumatic stress disorder. So about 65% of people with post-traumatic stress disorder will meet criteria for generalized anxiety disorder. When I talked about previous generations having had trauma and great trauma and the cognitive distortions, the idea that people become very labile, they view the world very negatively, they're aggressive sometimes, they have mood swings. The most severe manifestation of that can be something called complex PTSD, and that can birth anxiety in the people that are around that particular individual, right? I mean, you know, if you're raised by, you know, the guy from Rambo, you know, you're going to be anxious, right? And I don't like to frame it that way, but you know, it's just generation after generation of war. Yeah, absolutely. It could be. I mean, all of these disorders are relatively related, so they're all associated with a reduction of serotonin in the cerebrospinal fluid, as well as susceptibility to addiction. There's also a genetic component. There's something that I didn't talk about because it's kind of dry, but people who are pregnant and experience trauma actually do pass that on to their children. There's a process called acylation and methylation that happens to particular genes when somebody's in development. Not inherited. These are from the environmental exposures that they have. And this is something that is sort of on the cutting edge of the assessment of psychological disorders. But you can basically deactivate good genes for particular environments, right? So somebody who's growing up under, Mosul controlled by ISIS, right, will not necessarily need all the bonding and attachment that they have here in the United States. So there's actually a developmental process for that as a survival mechanism. Now, they come to the United States, that's not a survival mechanism anymore. Now you've really sort of gone awry. And that's a completely different topic. Yeah. Can you say that one more time? So could heartbreak cause somebody to overdose on Tylenol or Advil? Yeah, they could be, because a lot of times, particularly in folks that are less sort of stable, the world can seem very, very bleak when somebody, say, breaks up with a girl, or when somebody gets rejected by somebody, or they lose their father or their mother, and this is actually, if you're interested, it's been addressed in early Islamic books on psychological distress. Abu Zayd al-Balkhi in Masalih al-Abdan wal-Anfus talks about heartbreak. So does Imam al-Ghazali, and talks about the ramifications of poor attachment and depression coming and stemming from that. And in those instances, people get nihilistic, and it might not be the want to commit suicide or the want to actually end their lives. People impulsively take medications sometimes, and it's something that should be discussed. I mean, if anybody's feeling that way, obviously the community hopefully can make strides in being supportive, or as supportive as possible. Does that sort of answer it? Okay. Yeah? To help what now? To help themselves. Like, let's say someone's dealing with trauma, where should they go? Sure. So this is actually a difficult question to answer because, as many avenues as we have, we also don't have that many avenues. I'm an inpatient psychiatrist, and my dual diagnosis unit is inpatient, so it's when people get very, very sick that they need to be hospitalized. But there are lots of practices that I would say have reasonable approaches to treating these things. Core Psych is run by an Arab American psychiatrist. It's core psychiatry, I think. Also, Access can set people up with different organizations. If you really feel completely alone, or if somebody out there does, calling the insurance card, calling the number for the insurance card they have, can get them a referral to an inpatient substance use treatment, or potentially, an outpatient substance use treatment, or potentially an inpatient substance use treatment, or a psychiatrist. So sometimes, the best route, if the resources that are low-hanging fruit in the community aren't working, is just contacting whoever the insurance provider is. There are also free clinics that exist that have psychiatrists on staff. So I know St. Francis Cabrini Clinic in Detroit, Michigan. I used to work there. They have psychiatrists that come in and will treat people. Now, I don't know that they have Suboxone licenses, so they might not be able to treat people with severe opioid use disorder, but they can certainly treat others. And I believe Al-Huda Clinic also has psychiatrists that come around. And, those are the two faith-based free clinics that I can think of. Yeah? Trauma and PTSD? Sure, they can vary dramatically, and in fact, if we have any, social workers in the audience or anybody who's a psychologist, they could probably attest to how wide an array of symptoms post-traumatic stress disorder can have and how different it can look. So what I said earlier was that there was an autonomic side of things, so somebody who's very jumpy, who's looking around, who's very labile, who looks like they're basically out on a battlefield, and then somebody who views the world extremely bleakly. The typical sort of historic active phase symptoms of PTSD are nightmares, flashbacks, re-experiencing, avoidance of certain things. So, I mean, my mom, God bless her, you don't talk about anything to do with the military with her ever, like that's, whatever. If it's a gun, if it's this, if it's that, just, it's complete avoidance, Not that she has PTSD, but it's sort of an example of people that have been put in those precarious situations. So it can look very, very broad. Sure, I think somebody raised their hand in the middle somewhere. I don't know. Or maybe I was saying things. All right, go ahead. Okay, does anybody else have any other questions for me? All right. Oh, yeah, go ahead.
I wanted to ask, how can people break the cycle of intergenerational trauma?
So breaking this cycle of intergenerational trauma, that's a very loaded question. I think the first, it's kind of like beating a dead horse, but destigmatizing mental health. I think the best way to do that in the community, particularly for the elder generation, is to point to old writs that dealt with trauma, calamity, and mental health, like I was talking to the young gentleman over there about Sheikh Abu Zayd al-Balkhi and Imam al-Ghazali. Those are individuals that have written about stuff like this. As long as humans exist, they'll experience trauma. It's whether or not you can acquire treatment for that trauma or not, and also about the environments that you're in and the susceptibility you're in. Like let's say somebody develops a substance use history. They're not going to be able to treat trauma if they're also addicted. You need to put out one fire before you put out the other. So it's difficult, but I think that's up to the community to sort of come together to destigmatize some of these things and to get people into appropriate treatment. Yeah. Yes, it is. So there are several treatments for PTSD without medications. The gold standard is trauma-based cognitive behavioral therapy, which is very painful and very difficult to do. You need somebody I would prefer to send somebody who's certified in it. There's re-experiencing therapy. There's a reimagination, basically. People that are having severe nightmares, you coach them through changing what the quality of the nightmare is or what the end of the nightmare is. So it's mostly cognitive behavioral therapy. EMDR exists, kind of a controversial. It's basically a type of therapy where they move your eyes a certain way. Sometimes it can be your hands while they're talking you through the trauma. It doesn't really separate from regular trauma-based cognitive behavioral therapy, but those are the non-pharmacologic interventions to PTSD treatment. And those are also the gold standard. I mean, somebody should, preferably if they're under relatively okay control, pursue a non-pharmacologic route first. But if symptoms are severe, I mean, we have medications that are just blood pressure medications that can reduce nightmares. Why wouldn't somebody take that while they're in therapy? They're not addictive. They have relatively few side effects. I prescribe stuff like that. That's good. Go ahead. Yeah. How long can trauma last? Trauma can last as long as conflict lasts. And the longer it lasts, the harder it is to treat. But basically, if somebody can develop symptoms of a trauma disorder in the first month, and in 90% of cases, they'll resolve in the first month. In the cases in which they don't resolve, they develop into PTSD and usually get more severe without appropriate treatment. They can be lifetime. They can be lifelong. You had a question, I think. Sure. Yeah, you can get addicted to using a drug one time. Probably the Best example of that is nicotine. That's been substantiated in studies. So that's an easy answer. You know, it's counterintuitive because you're like, how weak is my mind that I'm going to get addicted to a drug if I just do it once? But I mean, people really do get addicted to drugs by just doing them once. What was your second? Addiction versus dependence. So, you know, those are two really abstract terms. If you're talking about physiologic dependence, it's kind of like the example I told you about before. Somebody who's drinking heavily, you know, drinking lots of alcohol, they're going to get seizures or severe withdrawal symptoms. They're physiologically dependent. Somebody who's using heroin or fentanyl consistently, they're going to go through severe opioid withdrawal. That's physiological dependence. Addiction, you know, social media. You know, who asked me about social media? Somebody did, I think. Yeah. So social media, you know, you're not going to become physiologically dependent on social media, but you're certainly going to develop a behavioral addiction to social media. Yeah. Did somebody back there raise their hand or something? Somebody? No. No? You guys are okay? Yeah.
So we hear about overdose in our community quite often in the past few years. It's become an epidemic nationwide. Now, how can families intervene, or friends or siblings? How can they intervene before, you know, the person struggling reaches overdose?
So before, it's like $1 million question. Before, you know, that would be great. Unfortunately, you know, sometimes people look at somebody who's 19 years old and they're like, that's my little boy. You know, they're not, you know, not as far as the American legal system is concerned. You try to be as supportive as possible. You try to hold as many events as these as you can, basically. You try to have as many speakers from as wide a variety of different disciplines come in and talk. Try to destigmatize everything, and that's how you treat that. As far as opioid overdoses, that's a very valid question. I think everybody should have a Narcan pen. You know, if you know somebody who's on, whether they're prescription pill opioids or whether they have a history of buying them off the streets or taking heroin or fentanyl, somebody should have a pen of Narcan, which basically reverses the overdose. Opioid overdoses are usually fatal if they're combined with benzodiazepines. In other cases, they're generally not. But in the last 3 months, I think in the Detroit area, almost none of the drugs being sold as what they were what they were. So ecstasy was marketed incorrect. I mean, it sounds absurd, you know, shoddy ecstasy marketing, but people were buying things that they had no idea what they were. You know, people were just overdosing by mistake. So I think that if folks know that there's somebody on their block with a heroin use disorder or fentanyl use disorder or who's taking prescription pills, I think it's worth, and you can get these things for free. You know, you can get these things prescribed by primary care doctors. Worth getting Narcan pens, basically, which you just give an injection to reverse. Yeah, go ahead. So it's a very good question because that's being studied at a series of major universities, and Yale has a mushroom clinic now. So it's an absolutely interesting area that nobody should pursue on their own, because if you take too much of a film, you can genuinely fry your brain. It's like a hair. It's a hair trigger away from that. Psilocybin, mushrooms are being studied in academic circles for the treatment of trauma, and they're usually combined with trauma-based cognitive behavioral therapy or re-experiencing treatment. They're being microdosed to an extreme degree, so very, very, very small amounts. They're not a film. I know people that have taken 8 films and have persistent hallucinations that will never, ever go away. That's terrifying. Not being psychotic, always seeing things that aren't there, but you're not psychotic. That can come from psilocybin use. And there's a genetic component, so that's not going to happen to everybody. It doesn't do anything to some people. In fact, the mechanism of action of psilocybin is still poorly characterized. We know that it can modulate dopamine. We know that it modulates NMDA, but we don't really know exactly what its active effects stem from.
So how do you determine the dosage of medications? My psychology professor told me that a psychiatrist, he knows. Kind of like I guess pretty ambiguous. That's why I have to keep people in inpatient services.
Yeah. So you always start with the lowest dose. That's exactly. So serotonergic medications take about 4 weeks till you get an effect. If you haven't got an effect yet, you go up. If you get about a 70% effect, you can slow down and give the option to the patient of whether or not to go up. For most people, there are studies that actually substantiate what effective dosages there are statistically. So, like, I can tell you with some degree of certainty that 150 milligrams of Zoloft will work for about 70% of the population, a lot better than 100. And I can tell you that the same studies show that 125 don't really do that much better. So you look at the patient, you look at the severity of the symptoms in the patient, and then you titrate and dose adjust appropriately. It also has to do with what other medications are on their medication list, because they can decrease the metabolism or increase it, which often happens, particularly in somebody being treated with for PTSD. Gambling, that's a good one. There are no FDA-approved treatments for gambling use disorder that are medical. There are, they're sort of through the grapevine programs. Gamblers Anonymous functions under the same 12-step program that Alcoholics Anonymous does, not backed by a whole lot of evidence. There's some research that if you were to categorize a gambling use disorder as an impulse control disorder, there's a medication called N-acetylcysteine. It's actually an over-the-counter supplement that might potentially help with that, but that's still really preliminary. You're talking about naltrexone antagonist. Yeah, so still sort of being studied, hasn't really shown great evidence to gain anything close to an FDA approval. But naltrexone has been used kind of nebulously for a lot of different things. I mean, sexual compulsions, OCD, people with certain behaviors and autism. So naltrexone just blocks basically everything, right? So, but the fallout of that is if you're doing the wrong thing, you can really have some negative outcome. The negative outcomes would be somebody feeling off. They wouldn't be like fatal or anything, but gambling use disorder is one of those things we don't have a whole lot to treat with. Yeah? Or were you raising your hand? Oh, I'm sorry. Oh, yeah. Okay, the question was, does trauma always have to do with big events, or can it be smaller scaled events? So both APAs, the psychologists and the psychiatrists, typically designate trauma as stemming from a risk to life or sexual health, basically, in some capacity. Now, there are a lot of people with a lot of good points that repeated sort of subacutely traumatic instances can cause trauma symptoms. They won't necessarily be the active phase symptoms, but they'll be the cognitive distortions that I talked about. So I talked about like the symptoms that you'd get from a pit bull chasing after you versus the negative feelings that you get, that are more in line with depression, anxiety, impulsivity, and labality. Chronic neglect, for example, right, which is something that would be like a trauma that's not a big event but lots of little ones, causes complex PTSD, or what we in psychiatry would also call, almost synonymous with something called borderline personality disorder, where somebody becomes very emotionally labile, stops having appropriate attachments, loses a sense of who they are as a human being or as an individual. So yeah, that has a different line of treatment. Even complex PTSD wouldn't be treated as traditional PTSD. It would be treated with dialectical behavioral therapy and mindfulness and distress tolerance techniques. But that's, a lot of people want to define trauma more broadly. But in the medical and psychological community, for the time being, it is major events. I'm sorry. Go ahead, and then you, and then somebody back there. Sure. Yeah. Sure. It really depends on how old you're talking about, because I think, probably, if we were talking about, if you look at the world in terms of development, and you're like Jean Piaget's, idea about when somebody's sort of a fully developed human being, and after the age of 11, it gets very difficult to control somebody's behavior based on premises like that. Not that you can't put in boundaries. You're going to have to be particularly, maybe more stern in some aspects, cut the power off. But But really, behaviors that people learn in childhood, they're very hard to break. And, we don't really know what gaming, we've never, throughout humanity's existence, we've never had iPhones and tablets, right? So, the generation, when I was a kid, we didn't even have, I didn't have a computer when I was a kid, right? So this is still like developmental psychology that'll be published in about 10 or 20 years. It's not substantiated right now. What we could say with some degree of assuredness is that more than 2 hours of screen time is harmful in adolescent females and increases suicidal thoughts by 3 times. So that's something that I can point to a study and say that exists. I think developing a good family sort of bonding atmosphere for young ones and having them sort of involved is probably the best way forward. Young man, I think you've been raising your hand, and then I'll ask you. Yeah. Can somebody repeat that? Minor trauma? It can be unhappiness, sadness, discontent, so feeling uneasy. If somebody's feeling anxious, it can be an upset stomach. They can get headaches. Those are symptoms of minor trauma. And a lot of times family can help, cope with some of that, unless they're the source, in which case, yeah. No, yeah, is PTSD self-diagnosed? I would highly advise people not to diagnose themselves. Sometimes it's a lot easier to see than others, but there's probably a 20th century trend of self-diagnosis that can completely miss the bill. Let's say you have somebody who's developing symptoms of psychosis. They're prodromal schizophrenic, right? So they might develop schizophrenia, God forbid. And you're like, they kind of look like they have PTSD. Well, you don't really want to say that. Let's say somebody has a borderline personality disorder or something like complex PTSD. You don't want to misinterpret that. So a clinical professional really should be. Yeah, go ahead. So a clinical assessment by a qualified mental health professional is how you would test somebody for PTSD. There's no blood test. There are some genes that are associated with a higher susceptibility of it. There are levels of serotonin and the absence of one enzyme that produces of serotonin that are associated with it, but there's no blood test for PTSD. Clinical assessment, basically. You want to say that again? What point is what? At what point does treatment become ineffective? I would say if the patient themselves doesn't believe in most psychiatric or psychological treatments, they are ineffective, largely because you need patient participation and buy-in. As long as they do, I think there's always a degree of hope. But some people are vehemently against this. Some people are like, no, you go to the masjid, you pray. You go to the masjid, pray. If you can't pray it away, you're sinning. There are some people with that mentality. Yeah, go ahead, back there. Mm-hmm. Yeah, it can be. So desensitization can treat hypervigilance. Medically, something like a blood pressure medication, propranolol and prazosin, those are 2 blood pressure medications that really shouldn't have psychological ramifications, but actually decrease the hyperactivity of the sympathetic nervous system. Those can treat hypervigilance. Hypervigilance is basically your heightened response to certain things in the environment. Like, let's say that door closes and makes a sound behind you. If you've been hearing shells fired your entire life, or if, God forbid, somebody was the victim of a break-in or a severe motor vehicle accident, the little, thump might be something that triggers them in terms of hypervigilance. Yes? In our community, yeah. Poverty? Yeah, poverty can absolutely be the cause of trauma indirectly. We're in Detroit. Most of the trauma that I probably deal with is from patients that have been sex trafficked, right? And people, obviously, socioeconomic status is not an exclusionary factor from being sex trafficked, but we're at the intersection of a few major interstate, and a lot of times, people without adequate social support who live in poor neighborhoods where pimps and drug dealers sort of run the streets are sex trafficked. That's a susceptibility to trauma. Living in a neighborhood where you're more likely to hear gunshots is, you know, you can look up sort of a neighborhood, what the median income is, and how many crimes have happened. You can look at it. That's how people like decide where they want to live for their kids, you know, where they want to send their kids to school. I mean, that's associated with poverty. So is it caused by poverty? Not directly, but poverty produces a lot of circumstances that makes the particular population susceptible to PTSD. Yeah. Yes, young man. Of severe trauma? They're sort of what I've been talking about, like the hypervigilance, the being very, very sort of keyed up, worried nightmares, flashbacks, things like that. Yeah. Yeah. Yeah, so for the trauma brain, yes, because those are very much in line with the re-experiencing. So the reason why your visual cortex, so this is a PET scan, so your eyes are closed. Your visual cortex should not be working. It's basically the area involved in processing in the back. Not working, but like it shouldn't really be working all that much. If you're traumatized and you're constantly seeing images of gore and death and chaos, it's working irregardless if you're looking at something or not. That's the problem with PTSD, is it's linking an event that happened in the past to your current state right now. So yeah, with treatment that gets better. The substance use too, the other image gets better, but sometimes it can take years depending on how long substance use has been. For PTSD, yeah. Yeah. Sure. I think a lot of times, you know, Arab Americans, don't acknowledge mental health issues, and you know the way that mental health manifests, if you don't say you're depressed or anxious, is physical pain. So you go to the doctor and you get tramadol, or you get, you know, Norco, you know, and you get a few of those, especially if you're a male, usually if you're a male, but also women. In 2016, the government cracked down on people being prescribed these drugs, because people were just being prescribed, you know, for absolutely no reason. Every individual in the United States had like four like 30-day scripts of an opioid. You know, it was insane. So the government cracks down, so all the doctors in the community stop prescribing all this stuff. So overnight, they create a host of people that are now all withdrawing. They're getting very sick. They're getting, you know, what we would call dope sick. And then those individuals have no other route to turn to because there aren't enough substance use professionals. There aren't enough people prescribing Suboxone. There aren't enough people to treat this. So they turn to the streets, and maybe they buy a few Norcos off their friend. And then they go to a dealer, and then they start to buy heroin that they don't necessarily inject. I think amongst the Arab American population, intranasal use is more common. But then heroin is more expensive than fentanyl, and fentanyl has been being imported from China, even though it's 16 times stronger than heroin. So people are getting their heroin cut with fentanyl, and they're taking that, whether they're injecting it or snorting it, and they're accidentally dying. And in fact, 3 years ago, 3 years ago, when this was at its, you know, people didn't even know they were about to overdose. People died and had no intention of dying. You know, they would get admitted to psychiatric facilities. I don't know. I did my same amount. You know, I did my 1 pack of heroin, but it wasn't heroin. You know, that's probably the issue, and I think that's why that's growing as a point of susceptibility in our population. Yeah. Absolutely. You know, cultures that are somatic in nature, so ours and the Latin American culture, I would say, have a lot of somatic manifestations towards psychological illness. You know, people don't have a problem taking a medicine if your arm hurts. They have a problem taking a medicine if you're depressed. So it's easy. Yeah, take 2. I felt a little better. I want to feel twice as good. it doesn't sound bad, you know? It really doesn't until it is bad. Yeah, actually, go ahead back there. I think I don't. No, the vast majority of trauma doesn't lead to PTSD. There's some degree of genetic susceptibility. There's a degree of how ready you are for the trauma. There is a degree of how much support you have immediately after the trauma. And even when people start to develop symptoms of PTSD, about 90% of those will resolve in the first month. I think the issue with the population that I'm talking about is the journey to the West was not just one major trauma. It's like, you know, a dictator destroys your village, and then a militant group comes and starts capturing men and conscripting them and cutting their heads off, and then you go live in a refugee camp for 6 months, and then another military group comes and, you know, maybe takes your daughter away from you, and then you have to go to another country, and you're looked upon as a second-class citizen, and then you make your way into Europe, and half your family's dead, and then you get assaulted by a bunch of, EU, potentially guards or whatever, and then you get put in a detention center. It's not. The issue is the frequency of grand sort of traumatic events that happens to the Arab population that winds up in the United States is so high that it probably, it's kind of like the minor traumas too. It's just all building up over the course of years and decades, and I don't want to belittle the circumstances of Arabs that come to the United States too. I mean, these are individuals who like I'm saying from my own experience, west side of Chicago, people that come here and they're on Wyoming and, they're working at gas stations and they're in less than ideal environments, and, you get a gun pulled on you a few times. I mean, that's rough, and people talk about this like it's nothing. This is just a fact of life for a lot of people. But then there's a fallout from it. Yeah. Huh? Last question, go ahead. Yes, yeah. Can mental illness cause physical? Sure, it can. The symptoms of PTSD can be very, very physical, right? So you could wake up in a cold sweat. You could wake up, your heart's racing. You can't breathe, right? Those are some of the problems with PTSD's autonomic symptoms. Anxiety disorders, especially, like I said, in populations that don't acknowledge that there are psychological disorders in said populations. You can have an upset stomach. You could have pain, which could lead to the opioid, crisis or mini crisis in our community. So yeah, mental health disorders can absolutely lead to physical disorders, not to mention the fact that morbidity, all-cause morbidity for people with severe mental health disorders like schizophrenia is like 3 times higher than the general population. I mean, dying of cardiac arrest is higher in that population. Okay, I think that's it, right? Or do you really want to ask a question? Okay, yeah, go ahead. Yeah. I agree with you, actually. I think that there are a lot of bad doctors. I mean, that's the easiest answer I have for you, is that there are a lot of bad doctors. There are a lot of bad healthcare professionals who don't really care that much. They don't care about, like, somebody's really anxious, they can have symptoms of inattentivity. Bam, they have ADHD. You put them on a stimulant, they feel a little bit better, right? But because they're anxious, it actually makes their anxiety much worse. So then you prescribe Xanax, which nobody should ever be prescribed ever. Xanax should be taken off the market. It's associated with all sorts of morbidity. And yeah, I've seen that. I've seen doctors create that and people be admitted because of that. That's a culture that needs to change within medicine. In the same way that doctors were prescribing everybody like a 30-day supply of like 50 milligrams of Norco, 5 years ago, and they didn't care about that. Things take time to change, and I think that will hopefully change with better education in the medical and psychiatric and psychological community as well.
I just feel like there's not a lot of information out
It depends on what the illness is. It really needs to be characterized by a competent professional first. You know, sometimes we don't put mental health on the same pedestal as like endocrinology. Like if you have diabetes, you can't really wing diabetes. You know, you sort of need blood work for diabetes. But it's really not. It's very complicated because it's so easy to misdiagnose and so easy to improperly treat, you know. So it's a very hard question to answer. I don't think I can answer your question appropriately to the degree that you want me to answer it. I'm sorry. Okay. Is that good? Thanks.